Mycobacterium tuberculosis. According to Burgess classification, kingdom bacteria, phylum Actinobacteria, order Actinomycetales, suborder Corynebacteriaceae, family Mycobacteriaceae, genus Mycobacterium, species Mycobacterium tuberculosis. These organisms are weakly gram-positive. Sometimes they won't take gram staining because these organisms' cell wall is peculiar with high lipid content. They are non-motile, rod-shaped bacteriums. They are normally stained with acid-phos staining. That's why they are called as acid-phos bacilli. They take acid-phos staining. They can grow at 37 degrees centigrade temperature like human beings, human body temperatures. At 68 degrees centigrade temperature, these organisms are catalase negative. At 37 degrees centigrade temperature, these organisms are catalase positive. So this catalase enzyme production by this organism helps this organism in preventing or in helping the growth of this organism inside the macrophages. It neutralizes the hydrogen peroxide which is produced by the phagocytes, and it produces niacin, and it is an obligate aerobe. We can see majority of the time this organism in the apex of lung regions causing infection, and is a facultative intracellular parasite. And this organism replicates very slowly. It has very slow generation time, that is 15 to 20 hours. The specific medium to grow this organism is Levinson-Jensen medium, and this is a egg-based medium. On this medium, it takes 4 to 6 weeks to grow. The colonies, very small colonies will appear, which appears as a buff colored colonies. And there is one more medium where this organism can be grown, that is Middlebrooks medium, which is an agar-based medium. It is not egg-based, agar-based medium. But for board exams, Levinson-Jensen medium is high yield. And on Levinson-Jensen medium, these are the small colonies which are grown with high power microscopy. You can see a small buffy colored colonies here. And on the right side, you can see the Mycobacterium tubercular bacilli which are in acid-phos staining. And in acid-phos staining, they look red in color, red color bacilli here, very small bacilli. And this is nothing but a cod factor or a serpentine like fashion, and this organism has one important lipid material called cod factor. Because of this cod factor, you can see the clumps of these organisms in acid-phos staining as well as in the growth. We can see these clumps. We can refer these clumps as serpentine fashion or serpentine cods. Cell wall. The peptidoglycan of this organism made up of a complex lipid. It consists of majorly 60% of this cell wall consists of lipids. Over 60% of mycobacterial cell wall is made with lipids. So these lipids are mycolic acids. Majority of this lipid content is mycolic acid. Because of this heavy mycolic acid containing in this cell, presence of this mycolic acid in cell wall, the name Mycobacterium comes majorly because of this mycolic acids. And these mycolic acids are long chain lipids. They inhibit cation proteins entry into this organism, lysosomal action on this organism. They prevent oxidative burst. Oxygen radicals inside the phagosome will be inhibited, and that prevents the oxidative burst on this organism. It inhibits complement activity. And because of more mycolic acids, it is hydrophobic in nature. So because of hydrophobic nature, it inhibits permeability. So the growth of this organism in culture mediums even very slow. It takes 4 to 6 weeks because of impermeability. And thus inside the cell wall, there is one more lipid called cod factor is present, and this cod factor is referred as trehalose 6.6 dimycolate. And because of this cod factor, we can see serpentine coding, and this cod factor is very much toxic to mammalian cells, and this cod factor also inhibits the PMN migration, polymorphonuclear cell migration, to the effector areas where these organisms are present. And this cod factor stimulates to produce more TNF, tumor necrosis factor, secretion from the macrophages and T cells. Because of more tumor necrosis factor secretion, we can see a low-grade fever in the infected individuals. We can see anorexia in the individuals. So because of anorexia, majority of the tubercular patients always loses weight and they will have a low-grade fever and evening sweats. The main reason for all these three symptoms is majorly because of tumor necrosis factor secretion, which will be stimulated by COD factor. VAX-D. VAX-D inside the cell wall is a combination of different varieties of lipids, that is LAM, lipoarabinomin, sulfatides, glycolipids. This lipoarabinomin always prevents the oxidative burst inside the phagosome, and sulfatides and glycolipids always helps this organism in attaching to the macrophages, and they also inhibit the phagosome lysosomal interaction. They can also inhibit the oxidative burst, and they prevent the acidity, or they prevent the hydrogen ion entry into the phagosomes, so that the pH won't be reduced and there won't be any damage occurs to this organism. So this organism inside a phagosome replicates because of all these virulent factors, COD factor, LAM, sulfatides, glycolipids. So virulent factors for pathogenesis. Adhesion. Adhesion occurs by binding to mannose receptors on macrophages with the help of glycolipid and LAM, lipoarabinominins, and they can also attach us to the FC receptors and complement receptors that are present on the macrophages. And some of the virulent Mycobacterium tuberculosis organisms, they produce pili. These pili also helps in attaching or adhesion to the host cells. Intracellular growth occurs with the help of COD factor. This COD factor always inhibits antibodies and complement activity, and it inhibits phagosome lysosomal fusion, and this COD factor is almost toxic to all mammalian cells. Glycolipids, sulfatides and LAM downregulate the oxidative burst mechanism, oxidative cytotoxic mechanism of phagocytes, and these organisms, they can produce catalase and superoxide dismutase enzymes. So by producing catalase, superoxide dismutase enzymes, it will inhibit the oxidative enzyme killing inside the phagosome. And these organisms, whenever they want to replicate, they require iron. These iron will be taken from the host with the help of siderophores. Immune escape and tubercle formation. Antigen 85 complex is nothing but a lot of protein molecules are present on this organism, and these protein molecules are combined together. They called as 85 complex antigen molecules or antigen 85 complex molecules, and these molecules always attaches to the fibrinogen which is present on the human cells, and that will prevent this organism from immune killing, immune cytotoxicity of the host cell. And this antigen 85 complex also helps this organism to form a tubercle formation by inhibiting the host cell immune function, and they helping in growth of this organism inside the macrophage can ultimately leads to form a tubercle formation or nothing but a granuloma formation. And because of slow generation time, this organism will slowly stimulate our immune system, so it gives this organism to replicate and to escape from the human immune system. High lipid concentration in the cell wall will have a lot of effects we'll discuss in the next slide. And because of COD factor, these organisms always inhibits antibody complement activity, and they also inhibits phagosome lysosomal interaction, and this COD factor can help in causing toxicity to the cells of host cells. LAM, lipoarabinomin, always helps in inhibiting the oxidative burst inside the phagosome. So high concentration of lipids in the cell wall helps this organism to impermeable to stains and dyes, so we can't have a staining, gram staining on this organism. So most of the time it will take very weak staining. After prolonged gram staining procedure, it will take a very light purple color gram positive stain, crystal violet. And because of high lipid content, it is resistant to antibiotics, resistant to killing by acidic and alkaline compounds, and resistant to osmotic lysis or via complement deposition, resistant to lethal oxidations and survival inside the macrophages. This high lipid content always make this organism highly impermeable. Coming to epidemiology, transmission always occurs by respiratory droplets. Each respiratory droplet, whenever we sneeze, each respiratory droplet can have 3 organisms. So for one sneeze, we may have an average of 3000 droplets. So whenever these droplets enters or inhaled by a person, so these organisms, majority of the droplets which containing this organism will be inhibited by our cilia, mucosa and upper respiratory tract areas. A very few droplets with organism, they will reach us to the lung tissues. That can lead to cause the infection. Approximately 10 million new cases every year all over the world, and low treatment complaints, and thus multi-drug resistant is a big problem nowadays. And most predisposing factors that leads to this infection is urban areas where there is a crowded schools, lot of crowded societies and military recruits. We can see this infection. HIV infected patients are more prone to get this infection when compared to normal individuals, and poverty because of poor socio-economic status can lead to have this infection, crowded living areas and poor immune system, malnutrition patients, they are always susceptible to this infection. AIDS is one of the major susceptible factor to have this infection. So TB case rates in US born versus foreign born persons in United States, and this survey was done in 1993 and 2006 in between. So here in this graph you can see the yellow one refers to foreign born people, and the pink one here refers to the US born people, and this is the average one, overall average one. So in foreign born people, we can see a lot of cases in foreign born people in between 93 and 2006, whereas in US born people there is a very less rate of this infection. So overall we can see the white line here, overall percentage. So here on the right side you can see the TB case rates in the United States. So the pink ones, the pink colored states here have more than 4.6% of the individuals or population will have positive for tubercular organisms. They are susceptible and positive for tubercular organisms. And here the sea green colored states are in between 3.6 to 4.6% are infected individuals, whereas the white colored states are less than 3.5% of the individuals. It was taken, this statistics was done in 2006. So pathogenesis. These Mycobacterium tubercular organisms always spread through respiratory route through droplet nuclei, and whenever they reaches to the alveolar region, alveolar sac region, where we'll have a lot of macrophages, we'll call them as dust cells. So these dust cells are inactivated ones, they are not specific to this organism. They always, whatever that enters, they will take these organisms. Whenever they take these organisms inside these macrophages are in the form of phagocytic vesicle, and this phagosome won't fuses with the lysosomal enzymes because of LAM, because of card factor, because of sulfatides, glycolipid. They prevent this phagosome lysosomal interaction. So whenever there is no phagosome lysosomal interaction, and inside the phagosome also there won't be any decreasing in pH. Normally inside the phagosome there will be a decrease in pH. Because of preventing this decrease in pH, these organisms, they replicate, and after replication they'll burst out this phagosome, they will enter into the cytoplasm, they replicate, and ultimately after replicating they will burst out this inactivated macrophages, and they'll come out into the tissues and they'll attract more macrophages, inactivated macrophages. So during this attraction into the inactivated macrophages, they will also stimulate to secrete a lot of TNF factors from the macrophages. Whenever they stimulate to release TNF factors, the T cells will also get stimulated and they will be attracted to that areas. So whenever these T cells are activated, CD4 T cells, they immediately releases interferon gammas. This T cell activation is sometimes can also occur with the help of MHC1 molecules. So because of this T cell activation, it always leads to release of interferon gamma from the T cells. These interferon gammas activates the macrophages. So whenever the macrophages are activated, these activated macrophages, they will surround this infected macrophages, and by surrounding this they'll make a granuloma formation. These granulomas inside in tubercular infection we can call it as tubercles. So we can see tubercle formation around these infected macrophages where these organisms are growing. So these macrophages, activated macrophages which are making this tubercle, they will pour enzymes on this activated on this inactivated macrophages. So whenever they pour these enzymes, that can ultimately leads to caseous necrosis. So whenever the caseous necrosis occurs in immune potent individuals, if the immune status of that patient is very good, and if that person has in the primary stages, you can see always this tubercular lesion which are made in the primary stages, they will get healed. The primary lesions heals, and this primary lesions which are made with tubercles will ultimately becomes fibrosed and they'll get calcified. So whenever these primary lesions are healed, whenever they get fibrosed, whenever they get calcified, the primary lesions, we can call it as Ghon's complex. So sometimes what happens is these organisms which are resistant to the immune system, which are more in number, which are bursting out there, they always makes a lot of tubercle formations. These growing tubercles, small growing tubercles, which always looks the size of millet seeds, and these tubercles, they can damage the bronchi, and they can enter into the bloodstream, and they can disseminate into the bloodstream, and they can spread all over the body. So whenever they spread all over the body, they causes the infection. Whenever they are causing infection all over the body, especially in the GI tract, bones, joint areas, gastro-urinary tract areas, peritoneal areas, or CNS system, we can call this extrapulmonary infection as miliary tuberculosis, which is disseminated from lung tissues to the other parts of the body. Miliary tuberculosis. So other way is, these tubercles which are formed in the lung tissues, sometimes by unknown mechanism they will get liquefied. Whenever they get liquefied, they'll burst out these tubercles, and the organisms which are growing inside this inactivated macrophages, they will burst out and they'll spread to the other parts of the lung tissues. Due to this burst out areas or bursting out in the lung tissues areas, it creates a cavity formation in the lung tissues. So in tubercular infection, if you see chest x-rays, most of the time we can see cavity formation, or sometimes you can see fibrous tissue formation, calcified lesions inside the x-ray radiographs of tubercular patients. So altogether, the pathogenesis is mainly occurring, or the tissue damage is mainly occurring because of our own immune system, cell-mediated immune system. This cell-mediated immune system, that is delayed type of hypersensitivity reaction, which is making to form granulomas, is causing the tissue destruction in tubercular patients. The major symptoms occurs majorly because of cell-mediated immunity, or type 4 immune response, or delayed type of hypersensitivity reaction. So here we can see a small animation.
Tuberculosis is acquired by respiration of bacteria that are in airborne particles known as droplet nuclei. When the bacteria enter the lung alveoli, they're immediately phagocytosed by resident alveolar macrophages, scavenger white cells of the immune system that roam the lungs looking for invaders to consume. Most bacteria, when they're phagocytosed by a macrophage, are rapidly destroyed, but the TB bacillus, the bacterium that causes tuberculosis, has learned how to exploit the macrophage niche to its own advantage. Rather than being killed by the macrophage after consumption, TB actually takes up a residence within the macrophage and replicates intracellularly. During the acute phase of infection, that is, prior to the emergence of a specific immune response, tubercle bacilli replicate within the macrophage inside the confines of tightly apposed membranous vacuoles, which divide in synchrony with the bacteria. Once the adaptive immune response of the host emerges, bacterial replication ceases. This is because the macrophages in which the bacteria are dwelling are activated by immune effector molecules, including cytokines such as interferon gamma. Activation of the macrophage creates a more hostile and nutrient-poor environment, which is not compatible with bacterial replication. However, wild-type tubercle bacilli are able to survive in this environment indefinitely, even for the lifetime of the host. In order to survive within the activated macrophage, we have found that the tubercle bacilli must switch their basic carbon and energy metabolism. When they stop growing and dividing, they turn on an enzyme known as isocitrate lyase, or ICL. This allows the persistent bacteria to utilize fatty acids as a source of carbon and energy. It's still a mystery to us why the bacteria are forced to use fatty acids during the persistence phase of infection. Mutant bacteria that are defective in isocitrate lyase and therefore unable to utilize fatty acids are deficient for persistence once the host immune response is engaged. Unlike wild-type bacteria, which survive indefinitely in the host, ICL deficient bacteria are rapidly eliminated by the host immune response.
Here we can see a short video of pathogenesis of tubercular organism.
Infection is by inhaling droplets that need only contain 3 bacteria. This is an incredibly small infectious dose. Most infectious diseases require more than 1,000 bacteria for successful infection. Sneezing is the most effective transmission mode, as bacteria remain airborne in small droplets for hours. Mycobacteria advertise to patrolling macrophages by producing proteins that interact with many host cell receptors. The arrest of phagosome maturation is a clear pathogenic determinant in tuberculosis. Mycobacteria prevent phagosome maturation using LAM, a mycobacterial cell wall lipoglycan, by a process that has not been fully elucidated. Acidification fails to occur and bacterial death is avoided. Phagocytosed mycobacteria induce a localized inflammatory response that leads to recruitment of mononuclear cells from neighboring blood vessels. T-cell activated macrophages attack infection sites, which results in the pathology of tuberculosis. Tubercles, cheesy white lesions, or caseation necrosis, are the hallmark of this debilitating disease. Mycobacterium tuberculosis can persist inside these lesions because they are hidden from the cellular immune response.
So TB infection is not considered as a TB disease. So TB infection is different from tubercular disease. So we can see the differences between tubercular infection and tubercular disease. In tubercular infection, you can see Mycobacterium tubercular organisms are present in tubercular infection. Whereas in tubercular disease in lungs, you can see the Mycobacterium tubercular organisms are present here also. Whereas the tuberculin skin test is positive in tubercular infection, whereas tubercular disease in lungs, you can see the tubercular skin test is also positive here. Whereas this tubercular infected patient, the chest x-rays will be normal, because these patients, they'll have a very good immune response, so you can't see any damage or infiltration in the lung tissues. These organisms are inhibited by cell mediated immunity in these patients. And whereas in tubercular disease, the chest X-rays usually reveals the lesion. You can see the lesions, cavity formations or fibrosis inside the lung X-rays. In the sputum smears in tubercular infection, sputum smears and cultures are negative, whereas in tubercular disease, sputum smears and cultures are positive. So you can see the organisms are growing, the organisms are present in the sputums. They are having an active infection in tubercular disease. So in tubercular infection, there won't be any symptoms, and tubercular disease, we can see the symptoms like cough, fever, weight loss, evening sweats, fatigue. And this tubercular infection patients, they are not infectious, and these patients, they are infectious. These disease patients are infectious and before treatment. And we can't define the tubercular infection as a tubercular disease. We can't define as tubercular patient or disease patient, whereas tubercular disease is defined as these patients are having an active tubercular infection. So in tubercular infection patients, the cell-mediated immunity is very much effective, so that these organisms are controlled by delayed type of hypersensitivity reaction by making granuloma formations. So these organisms are restricted. So at one point of time, in a potent immune patients, we can see the restriction of this organism by forming tubercle formations. Whereas in tubercular disease patients, these organisms can't be controlled completely. These organisms, they're replicating inside the macrophages, inactivated macrophages, and they're making tubercles and bursting out these tubercles, and they're spreading into the bloodstream and causing the miliary tuberculosis. So in these patients, you can see a prominent symptoms, whereas in these patients you can't see prominent symptoms. The tuberculin skin test will be positive. That means these patients are having a good immune response, cell-mediated immune response, whereas in these patients also they have a good cell-mediated immune response. With these, they have the active infection. Coming to the clinical features, in primary tuberculosis, we can see fever, malaise in the patients, and in chest X-rays, sometimes we can see black color patches on lung tissues and hilar lymph nodal enlargements, and we can see calcifications. So whenever these calcifications and hilar lymph nodal areas are infiltrated with calcification, we can call that condition as Ghon's complex. In Ghon's complex, the primary lesions will get healed because of cell-mediated immunity that can ultimately lead to form calcifications. We can call it as Ghon's complex. Whenever these tubercles are spreading or entering into the bloodstream by damaging the tissues, lung tissues, if they are spreading into the blood vessels and disseminates into the other parts of the human body, we can call it as miliary tuberculosis. Reactivation tuberculosis. So you can see majorly in elderly people, more than 50 years age group individuals, and we can see Simon foci. Simon foci is nothing but the organisms which are hiding, which are living inside the tubercles, calcified tubercles or normal tubercles. We can call them as Simon foci. So in some patients, the tubercles always have these organisms. Then these organisms, they won't replicate inside these tubercles, but they are viable for a prolonged period. Whenever these Simon foci or whenever these organisms present inside these tubercles are reactivated in immune suppressed individuals or aged people, we can call it a reactivation tuberculosis. Simon foci is the main one which can lead to cause reactivation tuberculosis. So more prone people are immune compromised, malnutrition patients, alcoholic, diabetic patients, drug abusers, sudden depressed patients, people who are having a spouse loss, sudden spouse loss, spouse death, young pregnant females, AIDS patients. So in all these patients, we can see the reactivation of this Simon foci, and that can lead to cause reactivation tuberculosis. Symptoms, we can see dry cough, blood in the sputum, fever, chills, malaise, fatigue, night sweats, weight loss. And we can also see extrapulmonary infections of pleura, bones disease, bones infections. We can call it as Pott's disease. and we can see GI tract infections, we can see gastrourinary tract infections, and we can also see meningitis. Especially meningitis is seen in adult patients, and we can see the granuloma cells in the CSF. That is one of the diagnostic feature for identifying the tubercular meningitis. In CSF samples we can see fibroblasts, we can see plasma cells, epithelioid cells, giant cells, and these organisms. So that is one of the important diagnostic feature in meningitis of tuberculosis, tubercular organism. In chest x-rays we can see cavities in the lungs, we can see fibrosis, especially in the upper lobes below the clavicular areas. We can see the fibrosis of the lung tissues in the chest x-rays, and if these patients are untreated, that can ultimately lead to death within few years. So diagnosis, we can diagnose by tuberculin test or Montauk's test. We can use this tuberculin or Montauk's test interchangeably, and in this tuberculin test the patient is given a protein purified derivative, that is tuberculin protein, intradermally, and within 48 hours if you see any induration around it, if the induration is more than 5 millimeters, it is positive, and you can see this condition in immune compromised individuals, high risk individuals, more than 5 mm positive, and low risk individuals, mostly healthcare workers, they will have a more than 10 millimeters induration, which is a positive, but they are having low risk. Why? Because the immune response is very much active. Because of immune response we can see the induration around that injected site. And people who are having no risk, they will have more than 15 millimeters induration. That means they are having a very good delayed type hypersensitivity immune response. So more risky people are people who are having 5 millimeters or more than 5 millimeters. They are more high risky people. That means their immune system is weak, and so that the induration is very much less around the injected site, intradermal injected site. In chest x-rays we can identify by observing the cavities, by observing the fibrosis, and by observing the lymph nodes, hilar lymph node calcification. We can diagnose with the help of x-rays. And LJ medium, Levinson-Jensen medium, we can culture this organism. It will take 4 to 6 weeks to grow, and for faster growth, for identification of this organism growth in culture medias, we have one system called Bactec system. Bactec system. In this Bactec system, these organisms will be growing very fastly, and we can observe by immunofluorescence. Radioactive material can be observed within 9 to 16 days. We can observe, because this organism can break palm-lectin molecules into carbon dioxide. So whenever it is breaking, so we can see, because of the radioactive material, we can observe the growth of this organism within 9 to 16 days. So here is the tubercular X-ray. You can see a lot of white material here, the fibrosis, and here we can see the cavity formation, the black color patches here, small patches, which refers to cavity formation. Whenever these tubercles get liquefied and bursts out, you can see the damage. We can get the damage of the lung tissues, which can ultimately leads to cavity formations. And you can see fibrosis, especially in the upper lung areas. In the right lung even, we can see the fibrosis of the upper lung areas. So in diagnosing these patients and treating these patients, this flow chart, which is released by CDC, is very much helpful. So first, whenever a patient comes, we can check the tuberculin test. If the tuberculin test is positive, we have to go for chest x-ray for the patient. So if the chest x-ray, if you see abnormal chest x-ray with symptoms, take the sputum and do the sputum culture. And if the sputum culture, if you find these organisms, so go for the treatment for tuberculosis, and he is having active tuberculosis. If the chest x-ray is normal and there is no symptoms, we can consider that patient as latent tuberculosis. That means he is having very good immune response, and he is having some tubercles, calcified tubercles with live bacteria. and take the sputum culture for that patient. If the sputum culture is also negative, there is no need of treatment for this patient. We can consider as latent tubercular patient, right? And coming to this, tuberculin test is negative. If the tuberculin skin test is negative, and if this test is negative prior to 12 months even, and there is no treatment is needed for this patient. And check for this patient if the tuberculin test is positive before 12 months. Check this patient again after 1 to 3 weeks later, and if after 1 to 3 weeks later, if the tuberculin test is positive, go for a chest x-ray. And if the chest x-ray, if you see any symptoms, go for the sputum culture. If the sputum culture is positive, go for the treatment. If there is no, in second test also, if you get negative results, there is no need of treatment. And these people who are positive, tuberculin test positive people, they are just infected peoples, and we can't call them as an active tubercular infected people. We can call the active tubercular patients whenever the chest x-ray has a positive results and the sputum results are positive, then you can call it as tubercular disease patients. If the tuberculin skin positive test, if at all it is positive, if there is no chest x-ray signs in the chest x-ray and sputum culture is also negative, we can't call that patient as tubercular disease patient. He is just a tubercular infected patient. That means his immune response is very good, and it restricted this organism by making the calcified tubercles and calcified tubercles around these organisms. Treatment. We can use for this the tubercular infection, always multi-drug therapy is advised. So first 2 months, isoniazid, rifampicin and pyrazinamide is given to the patient for the first 2 months, and for the next 4 months we can give isoniazid and rifampicin to these patients. So 6 months therapy can control this infection, active tubercular infection. So if drugs are resistant, if any one of these drugs are resistant, instead of that we can add streptomycin or ethambutol to this regime. Prevention by using UV light in hospital or crowded environment or theaters, crowded areas, we can use UV light. For UV light, these organisms are very sensitive and they will be easily destructed. BCG vaccine, Bacilli calmette and Gudine vaccine, and this vaccine is given to the majority of the population, but it is not used in US. In high risk families or people who are having tubercular patients in their families, they always can take as a prophylactic therapy ethambutol for 6 months.